We are live. So welcome to this morning's discussion, Psyfeld, the ex-girlfriend. So where would the group like to start?
Recording in progress.
So just to recap the episode, if everyone remembers, the main plot was George finds a girlfriend who he does not enjoy. And then there's the whole around that, like he's like, oh, I don't want to be with her.
How come?
Because she's too clingy. She felt the need to always be talking to him, always be calling him. And we find this issue with the character Seinfeld as well, where he's just like, oh, she's constantly calling me, she's constantly wanting to talk about this or that or just whatever.
So actually 2 points there begin to build a case formulation. Number one, the fact that we have now, for those of us who have watched Psyfeld, we know that these two male characters are very flawed, right? However, if you haven't seen all 9 seasons multiple times, and you get information from 2 separate collaterals, we can start to build on that. And that's certainly parallel to what we do in a psychiatric evaluation after an individual's self-report, and here we don't even have one. We do talk to collaterals, and what we begin to see is that there might be some pervasiveness of behavior from a particular individual, and that's the ex-girlfriend. Marlene?
Marlene.
When we begin to identify pervasiveness, not and more specifically pervasiveness that results in clinically significant distress or impairment in functioning, and in this case, interpersonal functioning, we may have a mental disorder, and that mental disorder may be a personality disorder. So that's the stepwise progression of thought from a clinician. Any questions? Because then there's a second comment that was made that I want to now throw into this, but before I do, any questions on how we got here, now ready to maybe talk about personality and personality disorder? Okay. You know what? I think before we actually get to the next point you made, I want to just go off on a bit of a tangent. In about 10 minutes for us, an hour plus for a formal psychiatric evaluation, where we're identifying a potential personality disorder, there are several things that the clinician must consider, investigate, and rule out before we can kind of land on there being a personality disorder. One is pervasiveness. What are the other 5 or so? I mentioned a second. For personality disorders, because it does contain the D word, there must be some clinical significance, right? Some clinically significant distress or impairment in functioning. So that's number 2. We have a good 4 more here to consider. Not that we'd ask directly to a patient, especially during the initial interview, but we need to tuck away in the back of our minds as clinicians because we're going to have to satisfy these. 2 down, 4 to go.
So are you asking like criteria for something being a personality disorder?
Something, yes. Let me just tweak what you said because you were like 99.9% there for every personality disorder.
Okay. Would it be something like, I don't know what you're getting at, like not better explained by a different diagnosis?
More specific.
Not better explained by another psychiatric diagnosis?
Okay, 3. So another mental disorder, right? So, for instance, if somebody actually is in the midst of a manic episode, they are dig fast.
Right.
You don't want to draw any conclusions on who they are as a person. Right? So that's 3. And I'm going to stick with your idea because when I asked you to be more specific, you could have said something else that'll give you 4 and 5 too. I'm going to stick to her idea. I'm not going to stick to her. This is anybody. Everybody's looking at.
Back to basics, it's not because of a different substance that's causing the behavior?
Number 4.
Substance use.
Mm-hmm. Similarly, if somebody that you're interacting with is impaired and drunk, you're not going to draw conclusions on who they are as a person.
And then underlying medical condition?
5.
Cool.
One more biggie. 4. Yep. Give you that one. The other biggie here is that not only must it be pervasive, it must be stable over time. Mm-hmm. Right? Not exactly the same, So pervasiveness is at any one point in time, it crosses over multiple social situations, work versus interpersonal versus other. And that has to be sustained over time. Personality, for the most part, is rigid. It doesn't change day after day.
Do personality disorders have like age criteria, like an autism or ADHD diagnosis? Like, does it have to be before 15 or anything?
No.
Okay.
No. Although the history is very consistent with that, though, in terms of taking it back, especially even developmental history. Now, having said that, there is one personality disorder. So the answer is no, but with exception. There's one personality disorder that does have an age criterion. Guesses? Bipolar? I'm sorry, borderline, no?
Narcissistic?
No, you're in the right cluster, though. There's only two more.
Histrionic.
One more.
Antisocial.
Antisocial personality.
It has to be over 18.
It has to be over 18. And the individual must have conduct disorder or evidence of conduct prior to the age of 15. So there are age criteria there. That's the only one. All right. You made a second point. All right. So we're investigating a potential personality disorder here, Marlene. And you use the word clingy. All right. So, now again, if the clinginess were something that appears to be stable over time and pervasive, and not just because of these two people these two individuals in particular, which probably is going on, right? What personality disorder, I think, now jumps up to the top of our list to further investigate?
I was leaning towards dependent personality disorder.
That's the one, yeah. Dependent personality. The word clingy is, it might be even in the definition in the DSM. Right, so that's the one to consider here. Individuals with dependent personality disorder do require affirmation and reassurance for their every next step, and that's despite their position. So, an attending should not be turning to their medical student and asking, "Should we do this? Are you sure we should do this?" Or a trainee. Now, you're going to hear me say, what do you want to do here on multiple occasions? That's more of a learning or teaching model. I reassure you. And I'll reassure you again later, and then even after that. But that's dependent personality disorder. Just because you listed all the cluster B personalities for me, and we've named now 2 of the 3 cluster C personalities, why don't you just tell me the other cluster C so that we fill in everything from cluster B and cluster C.
We have avoidant personality disorder, obsessive compulsive.
Do the other 2. Yep. All right. Brief pause. What questions do we have in terms of anything we just discussed?
At what point do we go from an anxious attachment style to a personality disorder?
That might be a continuum, right? The temperament may be that anxious attachment style that we uncover earlier in this individual's development. That results in or puts the individual at risk for a cluster C personality disorder in general and the dependent personality in particular. You may not be able to easily tease away one versus the other. It's not an easy task to look at any co-occurring anxiety disorders and wonder either or both. A little bit beyond the scope of our discussion this morning, but that's something that does come up not only in clinical practice, but on shelf exams too. Anything else on Marlene here? What other characters you want to discuss? The ex-girlfriend, Psyfeld.
Borderline. Is it borderline?
Borderline for who? You still focused on the character of Marlene?
Yeah.
Yeah? All right. So what borderline, the discussion of borderline is a little bit more detailed maybe than I think the discussions of other personality disorders, especially when you look at the cluster B and cluster C personalities. And the reason why is because all of the above really do adhere to a cardinal trait. And if you just remember the cardinal trait and you really understand that main part of the definition, the diagnostic criteria just morph into examples of that for you. And it's readily then identifiable on a shelf exam, except borderline. Borderline simply does not have that characteristic, that cardinal trait. So we have to talk about it in a little bit of a different way. And I think the discussion here begins with defense mechanisms. And this is a perfect discussion to have this morning because in a few hours from now, we're going to have a very similar discussion when we analyze our film. That's the teaser. What 3 defense mechanisms are characteristic, i.e. are likely to show up or appear on a shelf exam, in which the single best answer is borderline personality disorder?
Splitting.
Splitting. All right. So what is splitting?
It's like sorting people as like very positive relationship or extremely.
It's sorting
negative.
everything.
Yeah, everything. It's
Places.
like really good, really bad.
Right? Black or white
Shift,
thinking.
like very quickly.
Yep. What diagnostic criterion published in the DSM is a direct result of splitting? So splitting is not going to be your criteria, right? What is? Mood lability or affective instability, right? Those mood swings are the direct product of the unconscious defense of splitting. Individuals who have all or nothing thinking have all or nothing feeling very often, and therefore all or nothing behaviors. Follows in an imperfect continuum, right? So when you see affective instability, when you see mood lability, significant mood shifts, that's likely the product of splitting. 2 other defense mechanisms. What is passive aggression? And I'll give you a hint. Not the sociological term, but the psychological, Freudian, valiant, passive aggression. Passive aggression is the inward turning of a nihilistic impulse. Right? So give me an example of a nihilistic emotion or impulse. What might a person be feeling that could be nihilistic? A bad feeling.
Like hatred?
Right? Anger. Yeah. So, and the reason why I pimped you there is because I wanted to make sure that you also understood that anger and anger outbursts were actually a diagnostic criterion. Right. So, even though we're talking about defense mechanisms, there's another criterion that's linked to it, and that's anger. If an individual gets angry, if their course director just hawks you for an entire day, and you're like 3:59. Heading towards a holiday weekend, and you just had enough of him, right? What are the odds that you're going to say something to his face?
Low.
Very low, right? And you got to get the Rhyme P form is a bear to fill out. Right? You're going to have to do that. The EPAs are a real thing. You're probably not going to say anything, all right? However, if your anger needs to be discharged because you don't want to hold it in, your roommate might actually, and unfortunately, be the innocent bystander. That's called displacement. On the other hand, if instead of displacement, you employed, and this is not a conscious decision, passive aggression, you could actually have that anger turned inward. Passive aggression is a very common defense for individuals with borderline personality, and what might be the net result of that? Self-destructive behavior, suicidal gestures. And that's a diagnostic criteria.
Okay.
Right. You can see how the diagnostic criteria is very, very intimately linked to the defense.
Yeah. I feel like that's the only time defense mechanisms have really come up as diagnostic criteria, because we had to learn them for step stuff, but they're kind of this nebulous thing. It's like I haven't really tied this to any diagnosis.
Yeah.
That's cool.
They also link. I think the personality disorders in general link quite nicely to them. Now, when we talk about the cluster A's and cluster C personality disorders, they're not at the top of our list because they do have cardinal features, right, and they're more readily learnable.
Right.
Word.
I like it.
Give it to me. The other final defense for the borderline personality disorder is dissociation. Dissociation is actually the diagnostic criteria. Right. So you have 3 diagnostic criteria, and then one related: emotion, anger. Mm-hmm. And that's usually related to passive aggression. There are your 4 criteria for borderline that should give you the core to be able to identify it in a shelf exam. Mood lability, suicidal gestures, dissociation, anger
I
outbursts.
have a question about the mood lability. My understanding was that it was towards interpersonal relationships, but is that not true? Is it like towards everything? Then?
It could be towards anything. However, there's another diagnostic criteria that actually talks about interpersonal relationships, and it's interesting because every personality disorder can impact functioning, and interpersonal functioning is usually a prime example. I mean, you're more likely to have interpersonal functioning than academic dysfunction than occupational, but yet it is so pronounced in borderline that they got the general criteria and they absorbed it into the borderline diagnosis too. So that is another criteria. You don't see that in antisocial personality or OCPD or schizoid personality disorder, and where while all can and usually do affect interpersonal functioning, you actually don't see it as a singular diagnostic criteria. That's a good point. All right. So with all that now as the Uber primer to borderline personality, do we think Marlena has or might be afflicted with borderline personality disorder? Why or why not?
I personally would not think so because we don't see any of these characteristics. It doesn't seem so much. Well, there's towards the end that you could argue where she is splitting, where she's like, well, you have a really bad stand-up that I can't date you because you're just not funny. But I wouldn't say that is enough of a criteria to be like, okay, you do have borderline. I feel like that's just a preference. We don't see her experiencing mood swings. We don't see any self-destructive behavior. We don't see any dissociation. It's more of that described clinginess of she always needs to be talking to this person where it's negatively impacting all of her relationships that we see in the episode.
Yeah, I tend to agree. I mean, there's something there when it comes to self-esteem. It's a broad term. Identity and self-identity. Sometimes individuals feel so comfortable with who they are as a person that they could be in a room full of people and be ignored and it won't bother them. It doesn't change who they are, and they understand that. Then there's the complete opposite, and I think Marlena would maybe fit more towards that end of the spectrum where if she doesn't have things reflected back to her, reassurance that she doesn't have that internal locus of control to understand that she is good. Right? There's a whole bunch to discuss on that and far beyond the scope of this morning's didactic, but there are issues pertaining to identity. And by the way, that is consistent with borderline too. That's another diagnostic criteria when it comes to self-identity. That links to the dissociation criteria. Other characters, the ex-girlfriend, Psyfeld. Anybody else come to your clinical attention?
I am Seinfeld, so I think I don't want to take away from anyone. But to recap, there's also Elaine. If you all remember, she had met a person in passing, a friend of a friend, and they would acknowledge each other in the hallway. It would be like, oh, hello, and then it slowly just went down to hi, and then a nod, and then until they stopped acknowledging each other. And then that in her built up to a lot of animosity, where then she got extremely upset at the person who had just stopped saying hi to her. She was like, why have you stopped saying hi to me? Like, I know you know who I am. Made it to a whole big thing. And the person's response was, well, I just didn't want to say hi anymore.
Teaching point in psychiatry. Any thoughts here? So the individual says hi, and then that kind of evolves to a nod. Then to nothing at all over time. I do want to bring something up. It's a little bit of a loose association, but it certainly, I think, is, God bless you. I think that there's a place for this in psychology and psychiatry, and that is the evolution of saying hi to, quote unquote, just nodding. We have to keep in mind that about 60 to 80% of human communication is nonverbal. And there's a lot of different things we can say about this now, but certainly during a psychiatric evaluation and a psychiatric interview, what your patient doesn't tell you and what they show you is actually profoundly more important than the verbal communication. Right? Up to 80% of communication is nonverbal. And this is something that's not only important for the clinician to understand when they interact with people, but just as importantly, every physician must understand that with regard to their communication back to your patient. You could tell a patient it's going to be okay, but if your body language, if your bedside manner tells them different, they're not going to believe you. They're going to pick up on your nonverbal. And the reason why I bring that up is because twice per year, medical students have an elective where we bring you to a horse farm to actually learn nonverbal communication. We do that for our residents too. All right, so you could think that you're the most wonderful communicator that ever existed. But we're going to teach you that when you tell a horse it's okay, the horse is probably not going to understand your English. Probably not. What they're going to understand is your heart rate. And they're going to understand other things that you're actually cueing them. And they're going to withdraw from you. And we're going to take you into a didactic to teach you bedside manners through nonverbal communication taught through horsemanship. So 2 full days on the horse farm, and you will be a different bedside provider. Right. So we're going to actually end our discussion here. We're actually right up on the hour at 9 o'clock. We're going to ask the folks at home to log off and log right back on our table rounds. And for everybody else, we'll see you at noon when we discuss arguably the best film ever made.